Thanks for joining me. I'm going to review our quality improvement project in women's oncology at LCI about patient-centered care for patients with metastatic breast cancer during the COVID-19 pandemic. Disclosures are listed below. So the objectives of my talk are to review COVID-19 and impact on cancer care very briefly, oral anti-cancer therapy for patients with stage 4 breast cancer, and how to mitigate the impact of COVID-19 on patients with breast cancer on oral chemotherapy, and other opportunities to improve cancer care through lessons learned in the COVID-19 pandemic. So we'll start off with the question of what was on your calendar for 2020. And as everyone knows, our calendar is now spins around the COVID pandemic. So looking back at March, from a public health perspective, social distancing was the only way to prevent transmission. We had limited PPE, and before that, I wonder how many of us really knew what PPE was. And those of us in the hospital were told, quote, to wear a mask as long as it lasts. The workforce in medical hematology and oncology was deployed on a rotating basis to the inpatient care from March till June 30th, 2020, myself excluded. And that initiated Don Dizon's hashtag suits to scrubs for the duration of that period. Elective non-urgent surgical cancer cases were on hold, cancer screening was on hold, we had a no visitor policy, and we rapidly switched to telehealth whenever possible. But the Lifespan Cancer Institute, including radiation oncology, continued patient visits and treatments throughout the pandemic. From a patient's perspective, patients and families and friends feared the risk of COVID exposure when coming to the cancer center. In fact, one of my stage 4 patients was more concerned about bringing COVID home to her husband, who had severe oxygen-dependent COPD, than she was for her coming in for her own cancer care. And then there are the transportation barriers, particularly for the indigent population who may be coming to the cancer center by bus. Other patients coming in on ride services refused to come in, and even patients with cars who were unable to bring them in and were unwilling to face the valet service. And then the facility no visitor policy clearly was a barrier for our elderly and frail patients who had to be dropped at the door and then wind their way through the check-in stations. Our patients with cognitive dysfunction or anxiety disorders, many of them decided just not to come in to be seen. So I'm going to take a step back and talk about who is at risk for COVID-19 among our cancer patients. And we had many small reports coming out of China and other parts of the world in January and February. And it wasn't until 2 registries that were recently published that were initiated in March and April in Europe and the United States may begin to reveal what our patients are at risk for during the pandemic. And I'm going to review those 2 articles. So the first one was published in the Lancet in June, The Clinical Impact of COVID-19 on Patients with Cancer, a cohort study, which patients were accrued from March through April. They were either had active or previous malignancy, and they were lab test positive for SARS-CoV-19. And these patients were from the United States, Canada, and Spain. And the main endpoint of the study was 30-day mortality. And I'd like to point out that our hematologist, PM Egan, contributed patients and was a contributing author to this Lancet study. So in this study, baseline characteristics, medications, and comorbidities were gathered on a population of patients, with about 21% of them being breast cancer patients. 39% of the patients were on active treatment in the last 4 weeks, and 43 of the patients had measurable cancer. And again, the primary endpoint was 30-day mortality, which turned out to be 13%, which is higher than the average group of patients with COVID, And secondary endpoints, which are still being gathered, include clinical course of COVID-19 illnesses, including whether patients were hospitalized, ended up in the ICU, or on ventilators. But I'm going to refer you to these two bar graphs, with blue being solid tumor patients and red being hematologic malignancies. So on the first set of bar graphs on the left, the patients with solid tumors and hematologic malignancies, the ones with advanced tumors had the highest mortality. And if we shift over to the right bar graphs, for looking at what type of treatment they received, interestingly enough, in the patients with solid tumors, those who had received cytotoxic chemotherapy in the last 4 weeks actually fared a little bit better, although I think we don't have a lot of details on the patients. And there was no difference in mortality among the patients with hematologic malignancies with no recent therapies versus recent therapies. So from this registry, what they know so far, and again, with very short follow-up of about 800 patients, there did not appear to be an interaction of anti-cancer therapy and mortality, although there certainly was probably a lot of selection bias in the midst of the surge. Potential prognostic factors for severe illness is the same as the general population, which included older age, comorbidities, cancer progressing, or a worse ECOG performance status. So from the second study published in the same issue of Lancet, again, the cohorts were gathered in about the same period of March to April. About 800 patients who had received treatment in the last 12 months. And this was a population from Europe. The median age was older, as most cancer patients. There was breast, GI, and heme malignancies, and about 43% of patients had stage 4 cancer. And in the preceding 4 weeks, patients had received either chemotherapy, radiotherapy, targeted treatment, hormonal therapy, or immunotherapy. So of this population who were COVID test positive, 52% of patients had mild COVID and 28% of patients died of COVID. In the patients who passed away, the risks of death and univariate analysis included older age, hypertension, and coronary artery disease. And on multivariate analysis, there was no association with chemotherapy, immunotherapy, or targeted therapy received in the last 4 weeks. But there was a higher risk of death if the treatment goal was palliative, and that may have been related to what, in a resource-limited setting, where their patients may have been encouraged more to go on hospice with palliative goals rather than use ICU resources. So I'd say from these two studies, it's shorter follow-up. It's somewhat reassuring that in a United States and European population, there may not be as much impact of our cancer treatments, and that it may be safe to continue cancer treatments on our patient. But certainly I think we need larger populations with longer follow-up. But just to look at patients who live in the Providence area, if we look at the CDC's prevalence of medical conditions that may increase the risk of severe COVID-19 associated illness in Providence, patients having any of the following conditions: chronic kidney disease, COPD, heart disease, or diabetes or obesity, about 40% of the patients who surround Rhode Island Hospital are at risk because they have comorbid illness that may put them at risk for COVID-19. And what we've also seen in stark reality is the disparities in COVID-19 cases and death. And if we look at cases on the left and death on the right, Hispanic and Black non-Hispanic are certainly overly represented in poor outcomes compared to their representation in the general population, which led to an ASCO special report on the guiding cancer delivery during COVID-19, telehealth visits when feasible, cancer screening for state and local declarations for resumption, and consider home-based therapy, which leads into our project. So I'm going to briefly discuss oral anti-cancer therapies for stage 4 breast cancer and then circle back around to COVID. So the majority of patients with stage 4 breast cancer will live 2 years or longer, and in the majority of estrogen receptor positive breast cancer patients will live 5 years or longer. And there are several options for oral anti-cancer therapies along their treatment path. So for estrogen receptor positive patients, we have the CD4/6 inhibitors, palbociclib, abemaciclib, and ribociclib, along with letrozole, a CD4/6 inhibitor, and fulvestrant, which is intramuscular, exemestane and everolimus, alpelisib and fulvestrant for those patients who are PIK3 positive mutations. HER2 positive, we have lapatinib and capecitabine, and tucatinib and capecitabine. And for the triple negative patients, we have capecitabine and the PARP inhibitors for the germline BRCA positive patients. But there are unique risks inherent in oral anti-cancer therapies. The control of this toxic drug regimen is in the hands of the patient. They'll receive a bottle of pills in the mail from a specialty pharmacy that is not connected in any way from the Lifespan Cancer Institute, as compared to the patients on IV chemotherapy who have checks of their labs and how they're feeling each time they get IV chemotherapy by their doctors and nurses. These drugs have very complex dosing schedules. So for instance, the lapatinib capecitabine regimen is lapatinib 5 pills without food every day, and capecitabine 3 pills morning and evening with food for 14 days of a 21-day cycle. So it's frequent that patients get their medications mixed up. There's also the risk of medication interactions, safe handling, and as I mentioned, the drugs are shipped to their home by a specialty pharmacy, which is disconnected from Lifespan. And patients' lack of understanding of toxicity. If I call the doctor, they'll stop my medication. And patient compliance in terms of missed doses, and certainly missed doses may lead to an impact on efficacy. In fact, Anne Partridge recently published on this a review that adherence to oral chemotherapy ranges from about 66 to 100%. And reasons for lack of adherence include lack of knowledge. Why am I taking these pills? The financial barriers. Oral chemotherapy is limited in medical insurance coverage, and many of the targeted therapies cost about $10,000 a month. Side effects, level of self-efficacy by the patient, and patients just simply forgetting to take the medications. And ASCO has developed through their Quality Oncology Practice Initiative a safe oral anti-cancer therapy prescribing program, which at the outset, the practitioner prescribes the medication and specifies the drug, dose, schedule, and start date, and the patient signs a consent, and the prescription sent off to a specialty pharmacy. Then they have a nurse education program, which reviews their oral anti-cancer therapy medications, toxicity, and missed doses, and how to contact the prescriber. And then patients are contacted for a follow-up phone call 1 week later to review the dose and toxicity. And at a subsequent practitioner follow-up visit, the practitioner is expected to ask a patient about their adherence and document that adherence was assessed, and also work on strategies of what to do when patients are non-adherent, such as electronic reminders and patient calendars. So now I'm going to move on to the Pfizer grant that we have received for $50,000 to try to work with our patients to mitigate the impact of COVID-19 on patients on oral chemotherapy. So as we mentioned, patients with metastatic breast cancer may be at risk for severe COVID because of age and comorbidities, and the only way to prevent COVID infections is social distancing. And anecdotally, we hear every day patients are afraid to come in because of no visitor policies, their risk of contact with staff members, and valet parking. And so we have partnered with an existing home care agency, Hope Health, and have budgeted for about 30 patients to be followed every month or every other month with a VNA visit in which they'll take vital signs, and the VNA will help the patient initiate a video chat with the practitioner. And if the patient is unable to access MyChart, the VNA will help initiate the MyChart sign up and video chat. They'll also do a lab draw and also administer a quality life survey of 30 questions. We also have budgeted for our lifespan pharmacist to join us in the video chat. And this pharmacist will discuss oral chemotherapy compliance, including pill counts and confirm timely fills with the pharmacies to estimate adherence. Talk to the patients about their supply and time of taking, barriers to adherence, food and drug interactions, and also to help establish the next visit and labs. The provider team, either the physician or the physician assistant, will join the video chat with the patient and the nurse practitioner and discuss symptoms and side effects and grade them according to NCI toxicity. They'll discuss the plan of care, drug schedule. They'll discuss ways for the patient to prevent admissions to the hospital and discuss any triggers for palliative care telehealth call and reinforce our nurse sick line. And we have a formal documentation that will take place during the call, in which we'll check off barriers to care, including financial concerns, social support, symptom management, and then the most common symptoms of grading by NCI criteria of constipation, diarrhea, nausea, vomiting, and fatigue, and then review the plan of care, including the dose of meds, and establish the next visit and whether to contact our other support systems in the cancer center for the patient. We also have budgeting for additional staff for a layer nurse navigator to contribute some fellow interested to help in filling out our REDCap database on the project. So the endpoints of our project are percent adherence, with the goal being 90% adherence, including patient-reported adherence and the pharmacist validation of possession, patient-reported quality of life, COVID-19 infections, patient adaptation of MyChart, their survival and utilization of resources such as sick visits, ER visits, and admissions to the hospital. So for our initiation steps, the contract currently is under review by Lifespan. We have letters of support from pharmacy, LCI, Sue Korber, Hope Health VNA, and Don Dezan, the director of the Women's Oncology Program. The Lifespan IRB has approved an expedited review of this project as a quality improvement project. And we've had a core Lifespan administrative meeting, and we've presented it at the Women's Oncology Academic Group meeting. So the next step after the contract is signed is to meet with the pharmacy, meet with Hope Health. I have a call to review the project with risk management, and then to form a core quality team, including a fellow, and then to recruit about 30 patients with stage 4 breast cancer who are on oral chemotherapy. So barriers to care. So the VNA will go into a home, and if a patient has a smart device, internet, and has the portal, the patient will initiate a haiku video call. If a patient has a smart device but doesn't understand how to initiate the video call, which is the case with most of my patients at this point, the VNA will assist the patient with a Lifespan patient tip sheet. If the patient does not have a smart device and/or no internet, the VNA will use one of our project iPads with the project intranet and do a FaceTime with the provider. And I've discussed this portion with IT from Lifespan. So we hope to find out if this project, if VNA going into the homes and doing a video chat is acceptable to patients, or if they would prefer to come to the cancer center. And if this program is acceptable, Lifespan or other facilities could consider expanded home administration beyond oral chemotherapy. So several of our monoclonal antibodies are now FDA approved for subcutaneous use, including trastuzumab, pertuzumab and trastuzumab. Denosumab, a rank ligand used to modify bone-related events, is sub-Q. And gaserelin is a drug that's frequently given to our patients with stage 1 through stage 4 breast cancer as ovarian suppression, which potentially could be given in the home or at least off-site from the large hospital complex. Could we give intramuscular fulvestrant at home? Or could they receive IV zoledronic acid at home? And none of the meds I discussed above are vesicants or cytotoxic. We already are instituting patient-centered care with televisits and infusion sites throughout the state. And we're trying to encourage patients to come to some of the other infusion sites that are off-site from the hospital complex. And I would encourage everyone to let their patients know about our new Lincoln site, which is very beautiful and is only at about 10% capacity at this time. This graph shows how we rapidly pivoted from in-person visits to initiating of telehealth visits. So by April, about 50% of our visits were telehealth visits, a little bit lower percentage for May. And fortunately for June, we have more patients who are coming into the clinic for physical exams, but we're still doing about a third of our visits by telehealth visits. Unfortunately, most of our telehealth visits are televisits, and I think some of the barriers to that, teaching a patient to access the portal and initiating a video call would be best done one-on-one, such as in our nurse visit into the home project. Our other concerns with COVID include delays in diagnosis. So if we look at this, information was provided for me by Tara Szymanski from the Tumor Registry. So in blue is April of 2019, and in orange is 2020. And if we look at new cancer cases reported to the Lifespan Tumor Registry, there's been a dramatic decrease in new cancers diagnosed, and certainly we know cancer has not gone away. Our patients are just not coming into our facility. So I think by keeping the volume at the facilities lower, keeping the patients who don't need to come in home, using televisits, and reassuring our patients that they can have safe visits at our satellites and also at the mothership, we're hoping to bring patients back in for cancer screening, cancer diagnosis, and cancer treatment. And again, Norman Sharpless from the NCI has projected that there will be an excess number of colorectal and breast cancer deaths because of delays in diagnosis, but hopefully we can turn these numbers around by getting our patients to come in. And again, I spelled his name wrong on this slide, but Sharpless and Clef Hudis led a session at the recent ASCO education session talking about their dramatic decrease in patient accruals to clinical trials. There's been about a 50% decrease in NCI accruals and up to a 70% decrease in accruals to pharmaceutical trials. And now they're willing to consider patient-centered care and think about consent to trials via telehealth, allowing patients to have local imaging, particularly since scans are now digitized, thinking about meaningful labs instead of extensive panels of labs, shipping IND drugs to the patients, and being more flexible with minor deviations. And again, Cliff Hudis from ASCO Education Census says, our actions now all have to be patient-centric. And ASCO has developed a Road to Recovery task force, And Cliff's challenge to the task force is tell me why everything we did was for efficiency during the COVID pandemic cannot be continued. So I wanted to thank Don Dizon, who was the inspiration for the hashtag suits to scrubs. And fortunately, Don is back in his suits and wearing his mask. I think Don is on vacation this week. But I would be appreciative if anyone had any comments or recommendations on this, on our oral anti-cancer therapy program, or how we can also improve the patient experience for the patients.
Marianne, that was a great talk. I have a question, and we actually, there was a lifespan meeting today about talking about expanding services at home for patients for many different reasons. And so the question that came up is it better that, so, here you're using VNA nurses, and then you talked about, giving some chemotherapy drugs. Should we be trying to work on lifespan having their own outpatient nursing team?
So in my opinion, I think it should be an OCN nurse. And, if you think about the number of visits they'd have to do a day, I think Julie could generate, the number of people a day who get fulvestrant, subcutaneous, we're not even doing subcutaneous trastuzumab right now, but I think it would be better to do it with a nurse who's experienced taking care of cancer patients. Yeah. Now, it's possible that Hope Palliative Care may have nurses who have moved from the infusion centers into palliative care. But I think it would be better, rather than just a general VNA, to have someone with oncology experience.
That's interesting. I just mentioned Mary Ellen Danzer, our navigators, right next to me, and she's listening too. We don't have that many OCN nurses and outpatients. We'll have to really think about this. But these are great comments.
Several of our semi-retired nurses moved from infusion into Hope Hospice. Again, do they want to do that, and is it a part-time job? But I mean, I'm amazed at, I would be really interested to have Julie add up how many patients come in for an hour-long trastuzumab infusion in the adjuvant setting and in the metastatic setting. How many of our patients are on trastuzumab, pertuzumab? How many of our patients are on monthly IM fulvestrant? I mean, this could potentially be financially beneficial to them, rather than have a patient plopped out in the infusion chair and start chatting about their grandkids. Hi, how are you? Here's your injection. I'm out of here.
Yeah.
Marianne, oh, hi, it's Rachel.
I think you're on mute, Michelle.
Hold on. Is that better?
I can hear you.
I hope I'm not sorry. So so there's been a recent, I think there's an echo. I'm not sure how best to do it.
I can hear you fine. I don't hear
Okay. Okay. So there was a recent article from another cancer institute that had such a program that has been highly successful, using nurse practitioners in conjunction with oncology VNA program. And I could certainly get that information to you. Laura and I had started to look at how could we do this. It sounds like other people are thinking the same thoughts. Maybe the program that you're doing could be just the nidus to move forward with that.
And I had talked to Sue about it a long time ago. When I first put in for this grant, I was hoping that we could give fulvestrant, because several of our patients would still need IM fulvestrant. And unfortunately, you'd need a certificate of need from the state of Rhode Island, and you would need the nurses to administer fulvestrant. But I think rather than build another cancer center, we're talking about building more and more cancer centers and then having our physicians dispersed. Could we send out an army into the community? I have a little old lady, an 85-year-old, who came in last week with a new clavicular fracture from new metastatic breast cancer, 10 years out from her original cancer. And she's from South County, and she knows the exact mileage it takes to get into Providence. And certainly I can send her to EG, but I think Hope Health has done a fantastic job reaching our patients in their homes, and patients are afraid to come in.
Mary Ann, this is Roxanne. I have a question. I'm thinking about reimbursement. Are there issues with that for folks going out into the community if you're just sending an OCN? Or have insurance companies in other facilities done this and paid for it?
So I don't know that. I'm trying to think of something else. Well, I mean, we give 5 fluorouracil pumps at home.
Yeah, I mean, I'm just wondering, you're doing this on study, you're gonna get a subset of patients, and how long is the study gonna, be able to pay for their therapy at home? And, if they get used to that, I'm just wondering,
We're not paying for their therapy.
No, for the service to go out there. Sorry, I missed that.
Yeah, we're paying for a B&A, and
Correct.
it'll be made clear to the patient. And what we're hoping is that the pandemic will be over. The time, I'd say the time that most patients and Rochelle can give me her perspective. I mean, stage 4 triple negative breast cancer would probably be on oral capecitabine 6 months to a year, and then they'd really have to come into the cancer center for other infusions. The Palbo, Ciclib, they're probably on that for up to 2 years. But you're right, we have to make it clear up front. We're not paying for drug. We're paying for nurse time. And we're also trying to engage people to see if using the video visit can improve their experience. Many patients are feeling very socially isolated at home, and the cancer center is their only opportunity for social contact. So there may be patients who say thanks, but no thanks.
Yeah, true.
All right, any other questions for Dr. Fenton? Well, thank you very much for the presentation, and thanks everybody for attending and for the good discussion at the end. Thank you, everybody.